Tuberculosis, a patient review approach. And Paula Fujiwara and Rosemary Riley are here. Rosemary.
Good morning. I'm Rosemary Riley, a health worker in the Bureau of Tuberculosis Control in New York City. Our patient review approach has been key in reducing the epidemic of tuberculosis in New York City, an epidemic that medical experts and public health officials felt could not be controlled. Every 3 months, our director, Dr. Fujiwara, travels to each of the Bureau's 5 regions for the patient review. In each meeting, the staff report on all cases of tuberculosis from the previous reporting period to ensure that we adhere to our primary mission, that every person completes treatment so that the chain of transmission is broken. Imagine this room filled with as many as 50 workers, outreach workers, doctors, nurses, social workers, and administrators. We are fine-tuning our presentations, organizing notes, and anticipating any questions that might arise. Why did the patient take so long to complete treatment? Why didn't Dr. X follow our treatment guidelines? And finally, what can we do to further our goal of every patient completing treatment? Dr. Fujiwara sits at a table surrounded by mountains of records on all the patients we're going to discuss. An epidemiologist sits at our side with sharpened pencils, ready to record the outcome of the presentations. The patient review approach begins. One after the other, we stand and describe, often in less than a minute, what happens to the patient, what medication he took, and how many people did he infect with tuberculosis, and did they get evaluated? 3 hours later, every case has been discussed. Within minutes, the epidemiologist distills the presentation into a statistical report. The results are in. We have made our goal of having over 90% of all our patients completing treatment. There is clapping and cheering and a sense of pride in a job well done. The patient review approach is our report card, a quantifiable benchmark of our success, of our efforts. What makes the patient review approach innovative? In most tuberculosis programs, statistics are compiled by a lone health worker sent to a central office, but everyone remains in the dark as to whether the program has achieved its goal. We, on the other hand, we come together as a group. We report on our work, we give feedback and updates, and receive updates from our director. We share information about how we each were able to accomplish our mission. Absolutely no cheating is allowed. We must report on whether a patient died, relocated from New York City, was lost to our program, and most important of all, completed treatment. To keep us on our toes, we take our less optimal results and turn them into new challenges to be improved by the next patient review. Also, we are accountable for our work, and we use a team approach. Some of us contribute our language skills, and others have a street knowledge, or a knowledge of street culture, which is essential when looking for lost patients. And some work more closely with the primary physicians. By the end of the patient review meeting, we know exactly how well we measure up to the Bureau's objectives. I mentioned that most cases are described in less than a minute. However, every patient has a story, and I want to convey some of the challenges we sometimes go through to get a patient to complete treatment. Mrs. B was devastated when she was diagnosed with tuberculosis and HIV. She was convinced that she contracted HIV from her husband. When I encouraged her to take her TB medications, she said, "Why bother?" Because she thought HIV was going to kill her. Her husband physically and verbally abused her. She was engaged in a custody battle for her children and was faced with eviction from her apartment. Because of her sickness, she had to leave her job as a laundry worker in the hospital. Once she called me on the phone crying hysterically, that her husband attacked her. I could hear the apartment being torn apart in the background. Then the door slammed. He had left the apartment. At this point, I was able to allay her fears and help her to obtain social services. Through all the rough times, I stuck with her until she successfully completed her anti-tuberculosis treatment. Presenting Mrs. B at the patient review approach was a great joy. I had accomplished my goal. I would have done it for Mrs. B anyway, but knowing I was being accountable for our outcome and having to report it at the patient review, I strove for excellence. The patient review has helped turn the tide on tuberculosis in New York City. It is proactive, it is measurable, and results-oriented. TB has declined by 55% since we have started with the patient review approach. We have visitors from tuberculosis programs all over the world has come to learn how they can replicate our model and instill the energy and enthusiasm in their workers. Thank you.
Thank you. Questions? Please, Jack.
Dr. Fujiwara, it sounds like an admirable program. To my impression, there are also admirable programs in places like Baltimore and San Francisco. Could you compare your program with theirs, both in terms of when they started and how they work?
The Baltimore program actually started about 20 years ago when the health commissioner at that time felt that he didn't want to be first in the nation in terms of the number of cases of tuberculosis. And in San Francisco, where I also worked, they have had a well-run program since the early 80s. I think what makes our program different is this sense of coming together as a group. I mean, I know the San Francisco program while having worked there. And the issue there is that we actually come together, we take outreach workers, people who have not been trained in medical, had medical training at all, and we have them be the eyes and ears of the program. And by doing that, they are able to come back and say, these are the issues that are going on in the street. And I think that because of that, that's what has made our program a success. It's really a group process. Everyone comes together, everyone learns, and takes that information back to make the next approach even more effective.
How does that reduction rate in New York compare to the reduction rates in Baltimore and San Francisco?
I think that there has never been a parallel what we have seen, what we had seen in New York City compared to what you see in Baltimore and San Francisco. In San Francisco, just the magnitude has been different. For example, we have about 10 times the number of cases. But what has happened in the last 5 years is that we've had a consistent decrease of about 14 to 15% per year over the last 5 years. That has never been seen anywhere else in the country. And today, even looking at the data for this year, that decline continues.
Louis?
What was the greatest challenge to instituting your innovation?
I think that what happens in a lot of government, both city, state, and federal, is there's a sense that workers cannot change. When I came to the program in 1992, there was a sense of ennui. There was a sense of, yes, the cases are going up and we can do nothing about it. And I think that what I and the previous director did was just to instill the fact that we are different, we can do something about this. And it really was a sea change in having the outreach workers say that we can have an effect. Before, they weren't willing, they weren't able, they didn't have the training to even do this kind of work. But by giving them that kind of support, giving them the training, this is what has made it so effective. But it's really been a sea change in how people look at themselves and people have transformed themselves and their jobs.
Susan?
To what extent have you had a chance to give some thought to the applicability of your approach to other diseases, to other areas of where other social welfare areas?
I think that I call this a super case review. I think that this approach would be applicable to many other diseases where you have to bring people together. For example, Rose described the fact that we have doctors and social workers and administrators all coming together. I think that this approach can actually be applied to many other diseases. You just have to have that commitment and the sense of a mission, which the Bureau of Tuberculosis Control in New York City has a very large sense of. We are driven by our mission. So I think that any organization that has that sort of feeling of being driven can put this together. And the good thing about it is that it's extremely low technology in its best sense, because this was developed initially in a developing country, but our innovation was that we took it and made it into a group process. So I feel quite confident, actually, because we have innovated on an innovation, and not only in this disease, we've had a lot of interest in the country, but also I think that it can be applied to many other diseases, or not even diseases, but many other kinds of even social conditions.
David Osborne.
In other fields in the public sector where they use performance management, usually the review is done individually between a supervisor and an employee, or a manager and a supervisor, or whatever. And I think you're exactly right. The innovation here is this group review process. Can you tell us, do you have any indication, say, compared to Baltimore and San Francisco, or any other way of knowing, you know, what dimension, how much of the improvement you've seen is because of that group learning process as opposed to individual feedback on performance?
I mean, we do have individual feedback on our workers, but and I don't know what has gone on in Baltimore in terms of that actual process. I do know what's gone on in San Francisco, but it's a complex process. I mean, it's to say that one innovation is going to account for all of the effect is a very difficult thing to say. But I do think that I talked about this concept of a sea change. I really do feel that what we have been able to do is to say, we have a vision, we have a goal, we can make that goal. And I think that's been an incredibly important lesson for us.